You may be seated. We're back. We think that we have resolved our technical issues. Mr. Richters, you may continue.
Thank you, Your Honor. Doctor, I think you left off at the facts that went into support your opinion, correct?
Correct.
Doctor, I'm going to show you two pictures. They're side by side, and it's marked as Defendant's Exhibit. It's like 0025. Have you seen those pictures before?
Yes.
And did those pictures have anything to do with your opinion?
I certainly use them as a piece of the puzzle, and I found them concerning. You can see on the February 15th photo in Columbus that was obviously taken at the store, because you can see the things in the background, but you can see that Skylar is pregnant, and she's in her tight-fitting dress, and you can see a little baby bump there. But then when you compare it with the May 5th photo, I see very little difference in that. She still fits in her dress. To me, it doesn't look like she's put on any fat at all. Her breasts aren't at all bigger. Her arms aren't at all bigger. Granted, it's just one photograph, but I think at looking at her abdomen, looking at her dress, she doesn't look like she's gained any weight.
Doctor, exactly what was it in the interrogation videos and transcript that you reviewed that convinced you that Annabelle was stillborn?
Skylar, in her first interview on July 14th, I thought described, without any scientific knowledge of what a baby would look like, but she described a stillbirth that, from my perspective, when I've delivered stillbirths, what they are, and by definition what they are, which she described at least 20 times in one way or the other, that Annabelle was not breathing, she didn't see any movement, her eyes remained closed, and that when she held her, after she delivered her in the toilet, she squeezed her, and she was trying to see if she could feel or recognize a heartbeat, and she saw none. And then, on the 20th, early in that interview, she described Annabelle's appearance as being really white. And in my experience, when you deliver a healthy newborn, they're almost purple. They haven't yet pinked up because they haven't breathed any air yet. They're getting their oxygen through the placenta, and they almost have a blue to purple appearance until they let out that first scream. And also the other thing is that in that 20th interview, she remarked how the baby just plopped out of her. And it's been my experience in delivering stillbirths over the years, when they've been dead and died in the uterus, their skulls start to collapse, and the nurse will actually call us to the delivery room sooner than they may for a normal delivery, because it becomes a very unpleasant circumstance to have the mother just plop out of stillbirth in the bed, and they want to make sure the obstetrician shows up. And then additionally, and again, she would have had no knowledge of this, the fact that when she delivered in the toilet, that cord just snapped in two and was separated from the placenta, which she delivered sometime after. When we deliver a stillbirth and we're trying to deliver the placenta, usually when we deliver the placenta during that stage of labor, we can put a little bit of traction, or we pull on the cord. But in a stillbirth, the cords are very narrow. They don't really have the substance in them that gives them that tensile strength. It's called Wharton's jelly, and if you pull on it just a little bit, it'll snap right off the placenta, and that can cause a problem. So I think that kind of summarizes what I found. I may have left some things out.
You used the word snap. She didn't say snapped in an
It just
interview.
came apart.
She didn't,
It wasn't,
she didn't have to cut it.
right, the baby was attached to the umbilical cord, which was up around the neck or shoulder, but it was detached from the placenta, which was still in her uterus.
Doctor, I'm going to show you what's been marked as Defendant's Exhibit EEEE. What's that? What is that picture of?
That is a fairly healthy, typical, brand-new newborn that you could see his face is a little bluish purple, hands are still a little bluish purple, starting to pink up in the midsection there. The cord has been cut. You can tell he is, especially on his feet, notice the tone of his feet. He's starting to really get a lot of tone. He's got he or she, I don't see the genitalia to be honest, but got a grimace on the face and a good lusty cry, because when babies deliver, it's just it's even before they really need oxygen yet, but the reflex of babies when they deliver, it's one of the miracles of birth. They almost startle and start out with a very lusty cry if they're well oxygenated and ready to breathe that room air. And then once they take the big breath in, then that opens the lungs up, and then they just start wailing.
And if the baby's white, as Skylar described it in the interrogation, what does that mean?
It means that that there has been no oxygen exchange for a period of time from the mother through the placenta, through the umbilical cord to the baby, so that the prior to death, the fetus has essentially used up all the oxygen, and it has that, everybody's familiar with the pallor of death.
Dr. White, prosecutors hired Dr. Kim Brady to critique your opinion, and I provided you with his reports, did I not?
Yes.
And you had a chance to review those, right?
Yes.
And when you reviewed them, you had a chance, I take it, to review his summary, where he says, one cannot conclude based on the review of the aforementioned records that Miss Richardson's fetus was growth restricted and or stillborn. What's your response to that?
I disagree with his conclusions and came up with a different conclusion based on my review.
Did you see anywhere where he mentioned anything about anemia or nutritional insufficiency, or did he consider that in his reports that stuck out to you?
He did actually comment on the lack of evidence for anemia and used that as part of his rationale.
Okay, hang on one second. Doctor, I believe when he came in here and testified to the jury, he was referring to the Hilltop Obstetrics Group records. And these are the records of Skylar Richardson when she first went to see an OB on April 26. And I'm going to show this. Does this look familiar?
Yes.
And is that the results of the blood that was taken from Skylar?
Well, part of it is at the top, they did the toxic drug screen, which allowed me to conclude that nothing happened was due to any drugs she was taking. There's a urine test there that showed she did not have a urinary tract infection. The bottom of the page, it shows she did not have any sexually transmitted diseases.
I showed you the wrong page, but I'm glad you went through that for us.
I was waiting for you to get there.
Apologize. Doctor, you recognize that?
Yes.
Tell the jury what that is.
Again, these are routine initial prenatal labs we do on every prenatal patient. This page includes a syphilis test, which was non-reactive, meaning she did not have syphilis, rubella that shows she didn't have rubella, or she'd been immune to rubella, more specifically, and then not have hepatitis, and then down, as you scroll down, it starts with her white blood cell count, red blood cell count, hemoglobin, hematocrit, and it goes on down the page.
So what in that report, I think Dr. Brady indicated that she didn't have anemia, so he believed that there was no nutritional component related to this pregnancy.
Yes, he looked at the hemoglobin, hematocrit, which were on the lower end, but I agree with him, they were still in the normal range.
Could you circle that for the jury so they know what we're doing?
Blow it up for you, doctor.
Those two right there, the hemoglobin, hematocrit.
Okay, those two. So,
Will my pen work on this?
I'm sorry?
Will my pen work on this, or does it need my finger?
You need the finger.
Okay.
Is there, Judge, is there a stylus that he could use?
It'll be fine, we'll try to. But as I scrolled down, and the labs, because I don't want us doctors to miss things, so that's not good to miss things. See right there, that's an abnormality. And to the left, it says 16.2% with a normal range of 9 to 15. RDW. And I understand how he missed it. It's not something that we routinely do, but I thought that this was very interesting in that, because what I did is I went back to when she was at her lowest weight of 103 in the adolescent clinic with a doctor where her mother took her in where her weight was down to 103, and compared these results. And on that visit, the RDW was 12.1. So this was an abnormality. And what RDW is, it's an abbreviation for red blood cells, which makes up the oxygen carrying of your blood, that you need iron and folate and B12. The RDW is the red cell distribution width, which essentially means the size of your red cells. And when your red cells are all different sizes, that means your bone marrow is putting out these red cells to get them into your peripheral circulation as fast as the bone marrow can.
And why would the bone marrow do that?
Well, because if you have, if the bone marrow is trying to keep up with the oxygen needs, the blood needs red cells. So she is compensating, but barely so. And so what the red cell distribution width is telling us is that she's in a nutritional iron and B12 and folate deficient state, and she's just barely hanging on to that normal. So I agree with him that her hemoglobin and hematocrit were normal, but where I disagree with him is saying that this blood cell CBC result is evidence that she was not in a nutritional deficiency, especially when you look at the other factors or poor maternal weight gain, et cetera. So I disagreed with the fact that he concludes she wasn't in a nutritional deficiency just because her hemoglobin hematocrit were still within the normal range.
Thank you. Dr. White, Dr. Brady came in here and told the ladies and gentlemen of the jury that as to fundal height and its reliability, when you obstetricians take fundal height measurements every visit after 32 weeks.
24 weeks.
Thank you. After every 24 weeks, that it's only accurate 40% of the time. Do you agree with that?
No.
Doctor, I went through this with Dr. Brady, but I'll ask you, what is ACOG?
ACOG is the American College of Obstetrics and Gynecology, and they are the national organization that helps obstetricians maintain their expertise, maintain the quality of medicine, and one of their roles is routinely putting out publications. They put out a journal, they put out practice bulletins, they put out task force so that we review these so that we can keep current.
And when you say keep current, so keep current as to the standard of care?
To the standard of care of medicine, things change, so no matter how good our education is, you know, if you don't keep up with the newest and the latest, you're going to fall behind very quickly. So ACOG is our national organization that provides those, for a fee, provides those services to us, and we become members of ACOG, and then we have access to these things that are paper and now a lot of online.
And so these practice bulletins that are published by ACOG, and you and Dr. Brady are both members of ACOG, right?
Yes, we would rely on this information to shape our practice and also to reinforce that the way we're doing things is still current and the standard of care.
So simply put, it is relied upon by all obstetricians and gynecologists as to it's relied upon as state-of-the-art medicine.
Well, I won't say all, but the vast majority, so that we can still provide health care as safe as we can.
I'm going to show you what's been marked as Defendant's Exhibit KKKK. And obviously, it's one of the practice bulletins. This was also shown to the jury when Dr. Brady was testifying here today. The very top there, this is one of those publications by ACOG, correct?
Correct.
The date of this particular bulletin, it looks like it was reaffirmed, and I'm talking about, I'll circle it, 2018, but it first was published 2013. Is that correct?
Correct. And it also point out that it's done periodically because the May 13th bulletin replaced the practice bulletin from January 2000. So this has been something that, you know, the understandings of IUGR, or they title it fetal growth restriction, is not new.
Gotcha. But the point is, well, the point I'm trying to make is that this being reaffirmed here means that as recently as last year, what we're about to read here and what you're going to explain to us.
And also reaffirm means they republished it without any significant changes.
Let's go to the next page. Next page. Thank you for helping. All right. Which part? Top part. Doctor, there are several places on this particular page of this publication that I'd like for you to explain to the jury, if you don't mind. The first part, if I may, its section is titled Screening for fetal growth restriction, and I've highlighted the portion that I want you to discuss. If you don't mind, would you mind reading what I've highlighted there, please, so that the jury can not only see it up there, but they can hear it from you?
Fundal height measured in centimeters between 24 and 38 weeks gestation approximates the gestational age and is used to screen for fetal growth less than or greater than the 10th percentile. A single fundal height measurement at 32 to 34 weeks gestation has been reported to be approximately 65 to 85% sensitive and 96% specific for detecting growth-restricted fetus.
Okay, so tell us what that means.
So fundal height, the way we do it is we take a tape measure and we measure from the top of the pubic bone to the top of the uterus, which is called the fundus. And as I think I mentioned before, it's just a human coincidence that that fundal height measurement approximates the human gestation in weeks. So 32 centimeters, 32 weeks. However, due to human variation, there can be a variation. Where they use this is that you want to detect those fetuses that are in the lower 10th percentile, which means they're smaller than 90% of all other babies that gestational age, because it's the small babies that are at risk for intrauterine death. And sometimes I've explained to my patients, it's not like going out to the pumpkin patch and picking the biggest pumpkin for your jack-o'-lantern. We're going to let the big pumpkins grow. We're going to pull out the little pumpkins because they're going to die on the vine. So one of the most important things we do as obstetricians is monitor for IUGR. And this is the way we clinically do this by a simple tape measure of the fundal height. And if it's more than a 3 centimeter difference, then we become concerned and also looking at other risk factors that this baby could have IUGR. And also importantly, as they say, greater than the 10th percentile, because you want to tell the normals they're normal. So sensitivity, 65 to 85%, means that fundal height measurements will pick up 65 to 80% of those babies that are beneath the 10th percentile using that single fundal height measurement. And specificity of 96% means that those mothers that are normal at that measurement will not have IUGR.
Now, I'm going to go on down the page.
Doctor, if you test the lower left part of the screen, it'll clear off all your marks. Thank you.
So this same bulletin, this practice bulletin, we're going to look under this section, same page, clinical considerations and recommendations. This is what they're recommending to all you obstetricians and gynecologists, correct?
Correct.
Could you read that first paragraph for us and explain that to us?
So they asked the rhetorical question, how should pregnancies be screened for fetal growth restriction, and how is screening accomplished? Their answer is, all pregnant patients should be screened for risk factors for fetal growth restriction through a review of medical and obstetric history. Fundal height measurements should be performed at each prenatal visit after 24 weeks of gestation. A discrepancy between weeks of gestational age and fundal height measurement of greater than 3 centimeters has been proposed for identifying a fetus that may be growth restricted.
And then the next highlighted portion, can you read that?
Although other approaches to fetal growth restriction screening have been studied, including universal third trimester ultrasonographer, uterine artery Doppler velocimetry, which is very complicated, but it's measuring flow of the blood by Doppler ultrasound through the umbilical cord to make sure that that flow is wide open. Doppler volusimetry and measurement of analytes, which just means blood tests, such as pregnancy-associated plasma protein A, which nobody does. There is evidence that these growth restriction screening methods.
There is no evidence.
There is no evidence that these fetal growth restriction screening methods improve outcome.
So the two paragraphs are saying you should use the fetal or the fundal height measurement,
Yeah, that all obstetricians should be using fundal height measurement to screen for IUGR.
and that's just as good a screening tool as all the other things that you had just mentioned.
Yeah, they have not been proven to be superior.
That's great. Doctor, looking at your screen, this is from the same article. This is before, actually comes before the other stuff that you had just explained to us. That box there, the boxed in portion, explain to the jury what the box 1 says there at the top. What's the headline there?
Etiology, which is just a fancy word to say causes of fetal growth restriction, and it lists a bunch of things. None of them apply to Skylar until you get down to placental disorders and umbilical cord abnormalities, which is what happens when you have IUGR. You have a small fetus, a small placenta, a small umbilical cord, decreased amniotic fluid.
Then the next paragraph, so to speak, where it starts off at placental disorders and umbilical cord abnormalities. Could you read that?
Abnormal placentation, which just means the placenta is abnormal, that results in poor placental perfusion, i.e. placental insufficiency. So placental perfusion is the ability for oxygen to diffuse to the mother, carbon dioxide to go back to the mother, and nutrients to go to the baby, and waste products to leave. And if it doesn't work efficiently, that's called placental insufficiency, is the most common pathway associated with fetal growth restriction. So placental problems, often due to nutritional factors, is the most common antecedent to IUGR.
And you already discussed with the jury your opinion regarding the nutritional inefficiencies of Skylar Richardson, correct? Based on that blood.
We know her weight on July 13th, 2016 of 134 pounds, and her weight 11 days before delivery at the doctor's visit of 149 pounds. So she only gained, in the face of probably caloric restriction, 15 pounds. For someone her size, the recommended weight gain is 25 to 35 pounds. And then when she went back to see Dr. Boyce on July 12th, she was already under her pre-pregnancy weight. She weighed 130, so she was already underweight, which means that usually takes a mother typically 6 months to get off those healthy baby fat pounds, and it was gone, and she was less than her pre-pregnancy weight 10 weeks after delivery, which is abnormal.
Could you read this right in here for the jury, please?
I apologize for interrupting. Dr. Counsel, approach, please. may continue.
Thank you, Your Honor. Could you read this perinatal morbidity and mortality? Could you read that sentence under that, please?
Fetal growth restriction increases the risks of intrauterine demise or stillbirth, neonatal morbidity or a seriously ill baby, and neonatal death.
And that is true, isn't it?
Yes.
Yeah. Now, Dr. White, in your review of everything, what findings led you to conclude that Skylar's pregnancy was complicated by IUGR?
Well, I think I've answered a lot of that. Let me make sure. Her low fundal height, her poor maternal weight gain, her history of eating disorder.
What about the unknown gestation period? Or unknown conception period?
Well, certainly the no prenatal care, taking no vitamins, iron during her pregnancy. Yeah, unplanned pregnancy, no prenatal care. It all made her high risk for that.
Doctor, I think you've already indicated that you reviewed Dr. Murray, who is the forensic pathologist, whose report is attached to the forensic pathologist called by the state. It was attached to her report. You reviewed that.
Yes.
And you gleaned from that Skylar's baby was what?
39 to 40 weeks, consistent with what we knew.
And that's not a dispute.
No.
I know it's an obvious question, but I want the jury to understand this. Does IUGR that we've been talking about, does that increase the risks of stillborn?
Yes, substantially. If you're getting care at the doctor's office and you're going in for your twice weekly visits and delivered, we can minimize that, but even that, it's still probably 2 times. But if you're not going in for prenatal care, it may increase it 5, 8, 10, 30 times more likely to have a unexplained or a stillbirth.
Dr. White, does a fetal heartbeat of 140 beats per minute that Dr. Andrew heard when Skylar went to Dr. Andrew's office on April 26, does that mean anything to you or your fellow obstetricians?
It simply means that at that moment, the baby is not dead. It means the baby's alive at that point.
Does it say anything about the health of the baby?
No, you would need to do much more, not invasive, that's not the word I'm looking for, but you need a much more thorough exam of the fetal heart rate. There's testing that we do in the office called non-stress testing, where we put the baby on a monitor with a graph for 20 minutes and we watch the heart rate, watch the baby move, and the heart rate go up when the babies move to reassure us the baby is in a healthy state. Make sure that you don't see a drop of the heartbeat when the baby moves, because that can be the cord being compressed. So we do those types of testing of the heart rate to assure fetal well-being.
Doctor, when a woman is complaining about cramps, does that mean labor?
may or may not be. They all can cramp.
So, what about someone who's never been pregnant and they're naive? Would they know that when they have stomach cramps that they're in labor?
They may or may not. Sometimes they don't.
In your practice, do women that are your patients that come in and see you, do they often complain about pain?
I would say in pregnancy, probably at one time or another, it's pretty universal. They'll all have certain pains as they get further along in their pregnancy.
Doctor, does taking birth control pills while you're pregnant, does that in any way harm the fetus?
No. The only theoretical issue with birth control with one hormone in it is if you take it early on and you don't know you're pregnant in the first trimester, it could maybe masculinize a female fetus, or with the estrogen in the pill, since pregnant mothers have a lot of estrogen, it could potentially increase their risk of a deep vein clot and a blood clot to the lungs called pulmonary embolus. But taking a birth control pill in a term mother will cause no harm to the fetus.
Doctor, does IUGR affect the femur length of a baby?
It can. There are two main types of IUGR where the IUGR, the intrauterine growth restriction, affects everything in the fetus. We call that symmetric IUGR. Symmetric IUGR is usually more due to genetic abnormalities like Down syndrome or other trisomies, different infections like toxoplasmosis, things that affect the growth of the fetus from the time of conception. Asymmetric IUGR, where not all the parameters of growth are disturbed, is more, and it is called asymmetric IUGR and is the most common type of IUGR. And that is when you have some type of placental dysfunction or placental insufficiency. And what happens in the third trimester when the baby starts to really put on the weight, the femur has gotten long enough and will be relatively normal. The head circumference could also be relatively normal, but the abdominal circumference, the baby is like starving. There is no energy source in the liver, which is called glycogen, and the babies start to have very low abdomens, so that when you use the parameters for fetal growth to measure the growth on ultrasound, you will have a relatively normal femur length and abdominal circumference, but your abdominal circumference, excuse me, let me make sure I said that correct. You'll have a relatively normal head circumference and femur length, but the abdominal circumference will be very, very small. Essentially, just visualize a very skinny baby that's not being fed. And the calculation of the estimated fetal weight will give you beneath the 10th percentile. And these babies with asymmetric IUGR are the ones you must manage to prevent cord accidents and stillbirths from placental insufficiency.
And it's your belief, as I understand your testimony here
That
today,
Skylar had Skylar's fetus, Annabelle, had asymmetric IUGR.
does full term mean that the baby is of normal weight or is a large baby?
Full term is 39 to 41 weeks and speaks to the weeks of gestation. Full term, saying a baby is full term does not tell you anything about whether or not it's appropriately grown or small for gestational age or intrauterine growth restricted.
one more question. Yesterday, it was Mr. Knippen for the prosecution here, had identified as Exhibit 134H. It's one of the pictures that Skylar was taking of herself. And this picture, move it down, this way. Is that pretty clear on your monitor?
Yes.
Is that clear to the jury? That's a foot, that's her foot on the scale. What does that tell us?
Well, if she,
Well, I'm sorry, what does it tell you?
if she weighed herself,
Wait, I apologize. Let me interrupt. There's one little part of the question I wanted to ask you that's missing. We know that that photo was taken May 11th, 5 days after she gave birth to Annabelle. Now, what does that tell you?
well, what it tells me is that on May 11th, so 4 days, 8, 9, 10, 11, 4 days.
I'm bad at math.
This is actually, today's the first time I've ever seen this, so this is new to me. So 4 days after she delivered, that means that her weight was already 8 pounds less than her pre-pregnancy weight, which actually corroborates my conclusion that she was nutritionally deficient during her pregnancy because of her eating disorder, and she had no fat storage, because normally it takes 6 months to get that healthy fat off. And it gives me additional evidence to say that she had growth restriction from a caloric deficiency problem.
Thank you, Doctor. Just for the record, Your Honor, I would like to identify that portion of the police report that has been discussed 2 or 3 times in this case as Defendant's Exhibit MMMM. Thank you, Doctor.
Ladies and gentlemen, I think it makes sense for us to go ahead and break for lunch at this point. Remember what I have previously told you about the case. Do not begin discussing the case amongst yourselves, nor to begin form opinions about how the case should be resolved. Do not do any research or read any of the media accounts during the lunch break. Let's plan on being back here at 1:15 with the idea that we are going to get back going at 1:30. Counsel approach. All right, we're on the record outside the presence of the jury. Anything from the state? Anything from the defense? All right, we'll see everybody back here at 1:15 with the idea of getting going at 1:30. We're in recess.